Hi, my name is Brooke Kelso, and I'm going to talk about segmental pressures and PVRs. With PVRs and segmental pressures, the machine used typically is the Parks machine. There are presets for PVRs and for segmental pressures, so when you start your exam, you need to go in and pick which one you are going to be performing first, which is typically going to be the PVRs. We use a continuous wave pencil probe to obtain our waveforms during both exams, and this helps us listen to the blood flow and hear when the vein is compressed. This also allows us to know when to release the blood pressure cuffs and allows us to see and hear when blood flow resumes. A PVR is used to measure the change in a limb volume related to each cardiac cycle. For PVRs, we place blood pressure cuffs on both of the upper arms. We also put them on the thigh, the calf, and the ankle. And sometimes we can use what's called a four-cuff method, where we put two on the upper thigh. So we would have the upper thigh, and then we would also have above the knee. The patient should be in a supine position and should be allowed at least 5 minutes to rest before the exam. This allows them to have a resting heart rate and allows the exam to be performed more properly. The cuffs need to be snug and correctly sized for the patient's body habitus. And when putting on the cuffs, we need to make sure that they are snug. And the way that you can properly do this is you place the bladder of the cuff over the artery and try keeping the tube out of your way, which typically on the legs will be on the medial side, and on the arm typically will be the medial side of the limb as well. This will make it easier for when you are obtaining your waveforms and where you need to place your pencil probe. And typically the tubes will be facing down towards the patient's feet. So this will allow you to hook up your tubes to the Parks machine. These will be color-coded. Brachials will be red. The upper thigh will be blue. The above the knee will be green. Below the knee is yellow, and the ankle is orange. So it makes it pretty easy to hook things up properly. With PVRs, the blood pressures are inflated about 65 millimeters of mercury over the limbs, and this can be plus or minus 5 millimeters of mercury. The cuffs compress the veins, but they do not press the arteries. Set the PVR gain and scale to optimize waveform amplitude. PVRs are used to obtain waveforms of blood flowing through the arteries of the examined limb. These waveforms represent the sum of all blood flow through the examined area. This means that in patients who have obstruction to blood flow in some of their arteries, while still having viable collateral flow, the pulse volume waves may appear rather normal. So in the instance of collaterals, this exam is not as specific as we need it to be. With the segmental pressures, we do about the same thing. So whenever you're doing a PVR or you're doing a segmental pressure, you want to start with the arms first, and then you want to go to the ankles and work your way up to the upper thigh. With segmental pressures, there's two different methods. There's the 3-cuff method and the 4-cuff method. With the 3-cuff method, you will only have one 17-centimeter cuff on the thigh, and you will have one on the calf, so below the knee, and one at the ankle. And then, of course, you'll have both of them on your arms as well. And with the 4-cuff method, you will have the two on the thigh. So you'll have the upper thigh cuff and the above the knee cuff. These will be typically 12 centimeter cuffs up on the thigh. For the arms, depending on the body habitus, these will be 10 or 12 centimeters. And then as you go down, you will have 12 centimeters on the thighs, and below the knee you will have 10 or 12 centimeters. So this just depends on the patient's size. With segmental pressures, we, as I said, obtain the bilateral arm pressures first. And a pressure difference of 20 millimeters of your mercury or greater suggests a subclavian artery stenosis on the lower side. Then we begin obtaining the blood pressures in the legs, and we begin with the ankle, and we want to obtain a blood pressure from the posterior tibial artery and the dorsalis pedis artery. Then we want to move up to the calf, and then with the 3-cuff method, we move up to the thigh, where with measuring at the PTA, we don't need the DPA on these. And then with the 4-cuff method, we will start at the ankle, measure the PTA and the DPA, move to the calf, measure at the PTA, move to above the knee, measuring the PTA, and at the upper thigh, measuring the PTA. When interpreting both PVRs and segmental pressures, we interpret the exams by the waveforms and their velocities. Another way to determine the segment of disease is to look at the difference in the blood pressures. So if there is a greater than 20 or 30 millimeters of mercury difference in the blood pressure, that would suggest that there is disease in that segment. So the way it works with the blood pressure cuffs, so if the blood pressure between two cuffs is lower, that means that there's going to be disease proximal to the cuff with the lower blood pressure. So say that the upper thigh blood pressure cuff and the above the knee blood pressure cuff had a 30-degree difference. There's going to be disease between those two cuffs. With the 3-cuff method, you will have more accurate blood pressures, but with the 4-cuff method, you were able to distinguish better the difference between aortoiliac disease or femoral disease, just because you have two different segments in the upper thigh instead of just the one. To determine the severity of disease, we look at the ABI, and we can determine the ABI by taking the highest of the two arm pressures and the highest of the two ankle pressures that you got, so at the PTA and the DPA. Whichever one's higher, you will divide the ankle pressure by the highest of the two arm pressures, and you will do that for each side, and that will give you your ABI. So an ABI less than 0.9 is abnormal, and higher than 1.3 would be abnormal as well. So the normal range is 0.9 to 1.3. To determine, proximal disease will show diminished waveforms distally. So if there is going to be aortoiliac disease, we're going to see diminished waveforms all the way down the leg. And whatever side it's affecting more is going to be the side that their aortoiliac disease is on. And yeah, I think that's about it. Thank you.